and gentlemen, welcome to the IMPRO, Impact of Clinical Pharmacists on Diabetes and Hypertension Management conference call. Your host for today is Ms. Julie Campbell. You may now begin.
Thank you. Good afternoon, and thank you for everyone's patience. And welcome to today's webinar presented by IMPRO entitled Impact of Clinical Pharmacists on Diabetes and Hypertension Management. This event is part of our Diabetes and Hypertension Project, which aims to improve identification, treatment, and follow-up care for patients with hypertension and diabetes throughout Michigan. If you would like to learn more about this project, please visit mpro.org and select Diabetes and Hypertension Project from the Quality Improvement menu. If you would like to view this session again, a recording of the webinar will be posted to IMPRO's YouTube channel within the next week. Today, we're very glad to have Dr. Amy Cho with us today to talk about medication management of chronic conditions and integration of pharmacy services. Dr. Cho is the Associate Dean and a Clinical Associate Professor at the University of Michigan College of Pharmacy, the Director of Pharmacy Innovations and Partnerships at the University of Michigan Medical Group, and she is the Director of Michigan Pharmacists Transforming Care and Quality Program and Coordinating Center at the Statewide Collaborative Process Initiative. Before we turn it over to Dr. Cho, we just have a couple of housekeeping items to go over. Webinar participants can feel free to submit questions in the chat box at any time during the presentation. However, in the interest of time, we're going to hold all questions and discussion until the end of the presentation. We will also pull up a brief evaluation at the end for everyone to submit feedback about today's session. At this time, I would like to turn it over to Dr. Cho. Thanks so much for joining us today.
Thank you, Julie. So the objectives for our webinar today will be discussing the medication-related problems and key barriers to medication management in chronic conditions. We'll also discuss how clinical pharmacists can help to improve diabetes and hypertension management. And third, we'll share a best practice model to integrate pharmacists into primary care clinics. I wanted to briefly go over the statistics for diabetes and hypertension. We'll start with diabetes prevalence and control. In 2017, it is estimated that about 9.6% of the population, which is about 29 million people in the U.S., have diabetes, and 28% are undiagnosed. Blood pressure control is achieved in about a quarter of the patients with diabetes. For hypertension, it is in about 1 out of 3 adults in the U.S. have high blood pressure. Unfortunately, 17.3% of people with hypertension are unaware of the diagnosis. About half of the patients diagnosed with hypertension have their blood pressure under good control, and 37% of the people actually do not take their prescribed antihypertensive medication, which could explain the reasons why blood pressure is not under good control. I wanted to shift now a little bit to talking about the medication-related problems in the U.S. We find that drug-related morbidity is estimated to be about $200 billion annually, which is about 13% of our total healthcare costs. There's about 27% of the patients in ambulatory care setting have some type of adverse drug event, in which 39% were preventable. Medication non-adherence drives probably the largest avoidable cost, which is about $105 billion, and you combine that with additional $40 billion in annual avoidable costs for patients not being on evidence-based treatment. So these are opportunities where we can really leverage medication expertise of a pharmacist to help improve medication-related issues. Some of the key barriers to medication non-adherence, I'm sure you're familiar with some of these barriers as you interact with patients. Medication cost is a potential barrier to patients not adhering to therapy, and as the out-of-pocket cost for patients continues to escalate, this becomes a bigger issue for patients who are struggling with financial issues. As the patients age, patients are taking more and more number of medications, and the complexity of the regimen makes it difficult for patients to stick to their regimen. Third barrier is medication beliefs. I think a lot of patients have this perceived notion about the side effects of the medications, especially when they pick up their medications at the pharmacy, typically they get a long list of side effects that comes with medication. So I think patients have fear of taking medication due to the side effects. And also some patients actually may not even feel that patient doesn't need to take the medication. It could be because they perceive that they don't really have the diagnosis or that it's not necessary. Fourth barrier to medication non-adherence is depression. So a lot of the behavioral health issues that gets in the way of the patients being adherent to their therapy and managing their chronic conditions. So these are some of the key barriers that the clinicians need to be aware of as they're managing patients with chronic conditions. So how can pharmacists help given the complexity of the medications and the barriers that patients face, and also increasing prevalence of chronic conditions like hypertension and diabetes? The pharmacists have training and knowledge in how medication works in our body as well as what our body does to the medications. And through the training in doctorate degree of pharmacy, most of the pharmacists now graduate with a doctorate degree. And many of them continue to go on to residency training, which also then enhances and builds upon their knowledge they've gained during the pharmacy school. Pharmacists also have skills in working directly with patients, through patient counseling, and also pharmacists are trained in motivational interviewing to really understand patients, what motivates and what empowers patients, and leverage that strategies in interacting with the patient. Also, pharmacists who are embedded in practices actually have focused time in working with medication issues, whereas physicians and other care providers may not have that focused attention to medication. So pharmacists could really hone in on those issues and be able to really provide better understanding in medication use and management. If you look at the literature, the clinical impact of pharmacists, there was a nice meta-analysis that was published not too long ago, and it states that pharmacists provided direct patient care has favorable effects across various patient outcomes, healthcare settings, and disease states. Incorporating pharmacists as healthcare team member in direct patient care is a viable solution to help improve U.S. healthcare. And there's been about 300 studies that were included in the meta-analysis. And what they found that there was a significant improvement in A1C control, blood pressure control, lipid control, and preventing adverse events. Building upon the literature, and I'd like to kind of share with you what our experience has been in integrating pharmacists into primary care setting. In our practice model, we have 11 embedded pharmacists across 14 primary care clinics. But if you look at that 11 pharmacists, their clinical FTE is 5.2 FTE, and we also have secondary ambulatory care residents who works with us in the primary care setting. Pharmacist time at the practice sites may vary depending on how big or how small the health centers might be. So pharmacists might spend 1 day a week at one particular clinic, but 3 days a week in another. Pharmacists provide disease management and comprehensive medication review. I'll do a little deeper dive on each of those service lines in the upcoming slide. So for the disease management services, our focus area is on diabetes and hypertension, and we actively identify patients through using our disease registry or manning the provider clinic schedule to be able to identify patients whose blood pressure or hypertension might not be well controlled. Patients are scheduled for initial 30-minute visit with a patient, with a pharmacist, and then we also schedule follow-up ranging anywhere from 15 to 30 minutes to focus on improving disease control and medication management. Another service line we provide is really doing the comprehensive medication review. And for the initial appointment, we focus on make sure that patient understands what they're taking, if they have any concerns with the medication, make sure that there's an appropriate indication of use, and identify any barriers to treatment, including medication costs that we talked about earlier. We follow up with the patients in 2 weeks after we've done a thorough review of the patient's profile and also having discussion with the physicians that are involved in prescribing the medication, and come up with a treatment alternative to improve efficacy, safety, and lowering drug costs. So both combining the initial and follow-up, total experience could be anywhere from 75 to 90 minutes per patient. In terms of our practice model, we have pharmacists have full access to our electronic medical record and have bi-directional communication with physicians. We also have access to population-level data, including our metrics and gaps in care through our dashboard. Patients that are medical home pharmacists have also special clinical privileges. We've been approved by the credentialing committee in our system and have a collaborative practice agreement with physicians to be able to initiate and adjust dose and discontinue therapy based on delegated protocols. Some of our clinical outcomes, especially as it relates to diabetes, we have A1C. We've looked at patients' A1C difference in patients who managed by clinical pharmacists. We've stratified it into baseline A1C greater than 7, greater than 8, and greater than 9. And each of the cohort, we realized the A1C reduction of 1%, 1.4%, and 1.9% in these 3 categories. We looked at the type of activity or the clinical intervention done by the pharmacist. When we looked at the data across 1 year time frame, we had 2,674 medication interventions, which most of the half of the intervention was really on increased medication dose, and the other half was split between adding new meds, stopping the med, or decreasing dose. Now, pharmacists can't really participate in engaging directly with the patients unless we really get the buy-in from the physician. And every year we do follow up with the medical directors and health center managers to get feedback from the medical directors across 14 health centers to make sure that the pharmacists are being added value to the clinic and make sure there is that the physicians believe that pharmacists provide good care. They believe that collaborative practice agreements are a valuable aspect of their relationship. They believe that pharmacists provide useful communications and have appropriate clinical decision making. It's really important to engage the medical directors and make sure they're satisfied with the pharmacist's overall services. Now, I'd like to move a little bit into kind of our large Michigan Medicine Hypertension Initiative and share with you a little bit about some of our initiatives and our journey through that process. Our goal for Hypertension Initiative was to achieve the target blood pressure goal of 74% in patients with hypertension and 75% in patients with diabetes. Now, these two thresholds were set based on HEDIS goals of 90th percentile. So our goal was to hit that 90th percentile for HEDIS goals for hypertension in patients with diabetes. And our objectives were to improve the accuracy of the blood pressure that we're taking. Obviously, if you don't have the correct blood pressure, then you can't really make meaningful clinical decisions based on that. We also wanted to improve the appropriate follow-up appointments for patients with elevated blood pressure. In our initial look at the baseline data, we found that we're not appropriately following up patients who have elevated blood pressure in timely fashion. So we wanted to make sure that we have a process in place to schedule appropriate follow-up. Third objective was to improve patient engagement and education. So hypertension for patients been diagnosed with that for long periods of time either ignores the blood pressure or doesn't think that's a big deal. So trying to get them engaged and provide necessary education was an important objective to accomplish our goal. So one of our strategies in improving the accuracy of the blood pressure measurement is to have our medical assistants repeat the blood pressure in 5 minutes if their initial blood pressure is elevated. Oftentimes, the medical assistants might take the blood pressure as soon as they get the patient settled in, or and not really have the patient at rest and have the proper steps to take the accurate blood pressure. So we have built-in best practice alert, which alerts the MA if the blood pressure is elevated and prompts them to repeat the blood pressure in 5 minutes. And what we found that with the prompting and with the repeated blood pressure, that blood pressure is within goal or is lower in about 40% of the patients. And so what that means is that we have reduced our false positives for our physicians about 40% of the time, so that our physicians don't have to spend the time repeating the blood pressure. And why this is important is because in order for us to count the blood pressure in the HEDIS, it has to be a certain place in our electronic medical record. And oftentimes if a physician is repeating the blood pressure, they're not getting that blood pressure entered in the right place. So it's really important that we get the right blood pressure in with the medical assistant to help improve our adherence rate to getting our accurate blood pressure. To obtain our second objective, which is to improve blood pressure follow-up, this is where the pharmacists come into play. When the blood pressure is truly elevated, then within our electronic medical record system, we have a prompt that pops up an order for a physician. And for a physician, there is an order that states that blood pressure is elevated. If this order is signed before patient checks out, patient will be scheduled with a pharmacist in 2 to 4 weeks for blood pressure follow-up. So what this does is it alerts the physician, Mrs. Jones' blood pressure is elevated, and if they sign this order before patient checks out, that they will schedule an appointment with a pharmacist. So it's another trigger point for physicians to remind them that in midst of 20 other things they're juggling during the course of the visit, that don't lose sight of the elevated blood pressure. And then what happens simultaneously when the patient gets his order placed in their view of the EHR, the checkout staff gets a message that says, make sure the blood pressure elevator order is signed, because we want to make sure physicians have agreed to have a pharmacist follow up. And if it's signed, the staff is then automatically scheduling a follow-up with a pharmacist in 2 to 4 weeks. So this way we are leveraging our electronic medical record to put the right triggers at the right point for the right people so that we schedule blood pressure follow-up in patients with elevated blood pressure. Our third objective is to engage patients and provide education. Typically what happens within our EHR currently is that when patients get either diagnosed with hypertension or if we need to provide them with patient education, we print out 3 pages, single page, back-to-back, and patient education information. And for patients, that's a lot of information to process and to really understand. So we've developed an education tool, which I will show an example in the next slide, to get them engaged in the conversation with the physicians about their blood pressure. We also created an interactive voice response system, which is going to go live in September, which the voice response system will encourage patients to check the blood pressure reading at home. So it would serve as a reminder for patients to monitor blood pressure, and then they could enter the blood pressure into their phones, which then gets transferred to our electronic medical record. And so in real time, pharmacists can get that access to that blood pressure reading and be able to connect back with the patient if the blood pressure looks higher than what we would like it to be. So this way, we get the patient checking their blood pressure more regularly at home. We get the blood pressure readings back to the clinician in real time so that we can provide that point of care services in the moment that the patient is needing it the most. I'll show you this example of what our home blood pressure or education reading looks like. So if you notice in the middle box, we have the blood pressure goal for patients based on the J&C guidelines. And also there's a middle section where it says my blood pressure goal is, which allows the physician to specify what their blood pressure should be if it's deviating from what's standard across the HEDIS metrics, and then what the patient's blood pressure today is. So that way it gives a forum for physicians to have this dialogue with the patient in terms of what their goal should be and what the blood pressure should be. And then we also provide key information that would help the patient in terms of what their needs are, so the physician and the patient could talk through what resources would be helpful for them or what actual items that would be helpful for them to improve their blood pressure. And number 3, we've talked about how important it is for them to take their medication, and if they have any difficulties, for them to make sure they talk to the pharmacist or their physician. And then 4th is appropriate follow-up and making sure that they have some type of follow-up within 2 to 4 weeks of their elevated blood pressure. And then on the back side of the education is a home blood pressure log sheet where patients write down their blood pressure that they've taken at home if they choose to do so. Another initiative Michigan Medicine has started is to engage with a community pharmacy, and this is part of our effort to develop more of the patient-centered medical home neighborhood, so connecting with our community partners to meet the needs of the patients and connecting in that space. So for us, natural connection would be in the community pharmacy. So we're piloting this with 2 pharmacies out in the community in Washington County. And what we find that offering a convenient location and easy access for patients and have the opportunity to follow up in a community setting has been a huge patient satisfier. If you think about it, 90% of Americans live within 5-mile radius of a community pharmacy. Unfortunately, the current state of community pharmacy operates is based much more on dispensing medication, not so much on providing clinical care. And so this is kind of our first dipping of our toe into this space where we can leverage the easy access location or convenient location in an easy access with our community pharmacy partners. One of the things we wanted to make sure that when they are checking blood pressure, wanted to make sure the blood pressure technique and also the blood pressure check is accurate. So they have a blood pressure machine that's been validated by University of Michigan as a top standard in terms of accuracy. We've also given them access to our electronic medical record so that they have a full, clear picture of patients' care plan and any labs or other issues that they need to look at. And what's important part of that is to have that communication with physicians so that if there are issues that patients are reporting, they can communicate that directly with the physician. In order to do that, we need to make sure that these pharmacists have clinical training about managing hypertension. We also provide training in electronic medical records so they know how to navigate through our electronic record system to be able to read patients' chart as well as communicate with our physicians. So far, preliminary results so far has been the patient response has been very positive, and their experience has been more than we had anticipated in terms of their experience. I'd like to kind of step away from our Michigan Medicine within our health system, but kind of share with you a little bit about what's happening at the state level integrating pharmacists. Blue Cross Blue Shield and Michigan Medicine has launched a new initiative where we're integrating pharmacists into patient dental medical homes. And this was launched in late fall of 2015. And the objective for MPTCQ was to help the physician organization to identify and train and support the pharmacist transformation champions. So each of the POs who participated in this initiative had to hire pharmacists for us to be able to help support and train. And basically, they adopted the Michigan Medicine, the clinical infrastructure, but also modified it so that it's more tailored to their organization. Because implementing a program within academic walls looks very different than what it looks like in the community sector. So we've modified our process to make sure that we meet the needs of the community partners in that way. And third is to expand the training and support to other clinical pharmacists at their affiliated practice sites so that we could then spread that model across their enterprise. We've now had enrolled Cohort 1 in 2015 and Cohort 2 in 2016. So together, total, we have 16 physician organizations that are currently participating in the statewide initiative. We are about to onboard 5 more physician organizations fall of 2017, which will then total make up about 21 physician organizations across the state, out of 42 physician organizations within the state of Michigan. So that is roughly more than half the state, and we're hoping that through this opportunity to build clinical pharmacy program at some of the practice sites, each of the POs could then take that model and spread it across their network. So with that, I'll end the official presentation piece and open up the floor for questions.
Thank you so much, Dr. Cho. At this time, we'd like to pull up the evaluation questions. Attendees, please take a couple minutes to let us know your thoughts on today's webinar. We use the feedback from these evaluations in future learning sessions. So also at this time, we would like to open the line for any questions that participants may have for Dr. Cho.
Ladies and gentlemen, if you have a question at this time, please press the number 1 key. If you have a question at this time, please press the number 1 key. We're waiting for callers to join the queue. Ladies and gentlemen, at this time, if you do have a question, please press the number 1 key on your telephone keypad. If you do have a question at this time, please press the number 1 key. Still waiting for callers to join the queue. We have no further questions at this time.
Okay, well, again, I would just like to thank Dr. Cho so much for taking the time to speak with us today, and also thank you to all of our attendees for joining us as well. As a reminder, a recording of today's presentation will be available on MPRO's YouTube channel within the next week. So if there are no more questions, either in the chat box or in the telephone queue, we will conclude our session for today. Thanks so much, and have a great afternoon.
Ladies and gentlemen, thank you for joining this conference call for today. You may disconnect at this time.